Okay, great. Shall we start? Welcome, everybody. Welcome to the Cicely Saunders Institute Open Seminar series. So my name is Sabrina Bajwa. I'm a clinical reader and a palliative medicine consultant here at King's College Hospital and Guy's and St Thomas's. So I have a specialist interest in respiratory palliative care, and so it's great to be able to chair this session today. So every month the Cicely Saunders Institute hosts a free seminar series with speakers presenting on a range of palliative care and rehabilitation related research topics. So the seminar consists of a 40-minute presentation followed by 20 minutes for questions and comments, and you can ask a question by using the raise your hand function or writing your question in the chat box during or after the presentation. And please do, it would be wonderful to get as many questions and lively discussion as possible, and I'm sure there will be, because we have a great presenter today. So this is completely online presentation, so please could all everybody who's online make sure that you're muted, and if you can, it would be great if you could put your cameras on. It's always great to be able to present to a face rather than just a avatar. So the seminar will be recorded today for the faculty YouTube channel, and please don't try to record it yourself. So our speaker today is Emeritus Professor Miriam Johnson from Hull York Medical School. So this presentation will explore whether the use of opioids for chronic breathlessness is still clinically relevant, and Miriam was the chief investigator on the fantastic Mabel study, so we're delighted to have her here, and it will examine the different evidence from various trials and consider how clinicians can really interpret and apply this evidence in real clinical situations in the context of the recent European Respiratory Society guidelines. So I'll hand over to Miriam. Thank you.
So I think that should be the right window. I'm just going to check that that goes forwards and backs. Yeah, we're good. So lovely to be here. Thank you to Sabrina for your invitation. And I hope that we can talk together actually about this issue of how do you make sense of a whole evidence base, and what do we do in practice when you have data that appear to be conflicting. So without further ado, I'm going to take us through what I hope to cover. Firstly, we're going to revise just the key pertinent bits about opioids for breathlessness in the current European Respiratory Society guidelines. I'm going to take you back then to the basic science work, or some of it, some of the laboratory trials, and then into the pragmatic daily life trials, following and ending up with presenting the Mabel trial. And then just to have a think together about, well, what do we do with this? What next, if anything? How do we approach this sort of situation? So here we go. Hold on to your seatbelts because this is going to go quite quickly. So the current guidelines published, might even be 24 now, 24, 25, anyway, pretty recently, relating to non-malignant respiratory disease. So this is what they said about opioids. They said, oh, 24, there we go. I've helpfully written it down to remind myself. We suggest not using opioids for the treatment of breathlessness in people with serious respiratory illness, which they mark this as a conditional recommendation against, with a very low certainty of evidence. However, they give this some considerations which are interesting and helpful clinically. They say the evidence so far has focused mainly on people with COPD, therefore it is difficult to know what the true impacts on opioids are on symptoms in people with other serious non-malignant respiratory illnesses. Also, they note that the patient populations included in the studies to date have been heterogeneous, with some including people with only mild to moderate breathlessness. And they say that it's not clear if opioids are beneficial in people with more severe breathlessness, such as people who are breathless at rest or on minimal exertion. They also highlight that there's no studies, including people at the very end of life, who are the clinical group most likely to be given this for symptom palliation. They also allow that in this clinical situation where you're faced in that clinic room with a patient who is severely breathless, or in the hospital inpatient unit or hospice inpatient unit, or in the home, that you may still want to consider prescribing opioids to treat such symptoms. But if this is so, then there should be clear communication and shared decision-making between the clinicians and the patients as needed. This must include consideration of benefits and harms, and an active discussion and plans in place to manage side effects. Opioid prescription should consider patients' goals and the willingness to use an opioid, and their understanding of how to take it correctly, and to understand the broader impacts on their lives and other potential harms. Should recognise that other clinicians and patients and formal caregivers may require education and support regarding the use of opioids for symptom management in people with serious non-malignant respiratory illnesses. Sometimes we forget that palliative care clinicians and oncologists are very familiar with using opioids, but not necessarily all of them familiar with using opioids in respiratory disease, and then other specialties may be much less familiar with how to initiate and manage opioids. So why was the interest in the first place? Why did this story start? Well, let's look back at the basic science. What is the scientific rationale for using opioids for breathlessness? Well, we know that breathlessness perception is processed in brain areas rich in opioid receptors. So that seems a fairly reasonable starting point to say, well, if that is so, can we modify the perception by modifying those receptors? And indeed, there is evidence to suggest that you can. If you give someone an endogenous opioid, so this is the kind of opioids we all make ourselves, such as beta endorphins, for example, then on an exercise test, participants experience less breathlessness. If you give your exercise subjects an antagonist, so you're not giving them anything, but you are blocking their own internally produced opioids, that then increases their exertion-induced breathlessness, which seems to confirm that you can indeed modulate perception by messing about with what's going on inside people's brains. We also know from functional MRI studies of brain that remifentanil reduces the sensation of urge to breathe. We also know that the brain creates expectations and beliefs about the perception of incoming breathlessness sensation, which is based on previous experience. And we know that these so-called psychological priors influence that perception of the incoming breathlessness sensation. So if, for example, if you've had a really bad experience in doing, I don't know, running up the stairs, your brain will expect you to have that again the next time, and people will then experience it even if actually the incoming sensation might not be quite as bad. Our brains are phenomenally clever and tricksy in equal parts, I think. Now, we also know from these fMRI studies that opioids can suppress not only that urge to breathe, but these conditioned anticipatory brain responses to breathlessness. In people with chronic breathlessness, we also know that if they use morphine, they may get this, in these laboratory studies, they may get that reduction in breathlessness, and also in healthy volunteers using remifentanil, it may reduce their breathlessness. But we know that if they have anxiety or depression in any significant way, that can then reduce their opioid responsiveness. So something is going on centrally in the brain where these receptors are interacting with each other to affect that incoming signal of breathlessness. So the evidence points to a primarily central action. In general, nebulized opioid studies have not shown benefit except for two. One is in a specific population of people with COPD who were exposed to mustard gas, and the second is a crossover randomized controlled trial of 11 people with COPD. However, in both studies, there was no assessment, no measurement of systemic absorption of opioid. So we cannot exclude a central mechanism. So the other thing to consider, is this a class act? Is this all people or opioids? Well, the basic science appears to be that there's agreement about mu-opioid receptors from clinical and laboratory studies of morphine, fentanyl, and remifentanil. The story is much less clear for oxycodone, where the action is shared between mu and kappa receptors. Both studies have been negative, as in no difference, and in fact, Ferreria's trial in oxycodone actually showed that it was less effective than placebo, and there was no signal. However, it's a bit difficult because they did not do a standardized exercise test, but I think the jury is out for oxycodone. So that's those two placebo-controlled clinical trials of oxycodone failed to demonstrate any signal. The other interesting thing is looking at a pharmacogenetic study of people across Europe. Then people taking morphine these are people with cancer, people taking morphine were 3 times more likely to have worse breathlessness if they had a particular SNP on the HTR3B gene. However, there was no particular associative SNP identified for people taking oxycodone or fentanyl. So there may be some sort of genetic response to morphine for breathlessness that as yet we are unclear about. Oh, that's just to say there was no standardized exercise measure. I've already said that. So in summary, if we think about the basic science, it appears that our own endogenously produced opioids modify our perception of breathlessness. The evidence is for a central modulation as the dominant feature. Opioids reduce the sensation of urge to breathe. The response to opioids is reduced by an impaired affect. And opioids seem to be able to modulate anticipatory breathlessness as well as the sensation of breathlessness itself. And there is inter-individual, so one person's response is necessarily going to be the same as another person's response due to varying affective states and also their pharmacogenetics. So let's move it out of the basic science and the fMRI lab, and let's look at the laboratory exercise using exogenous opioids. So this is very controlled trials done in the lab, and where breathlessness is measured at isotime or isoload. That is, you know exactly what physical exertion that person has done to make themselves that breathless. And this is a really crucial point, and it's great to see Matthew and Charlie on the call, and they may well have some thoughts about this if we have time to chat later. So this is from the European Respiratory Society practice guideline, and they've collated very helpfully such exercise tests, and there is a clear benefit in favour of opioids. And the authors highlight that this is a clinically important effect size. So from that, we can summarise that opioids appear to reduce breathlessness at isotime and isoload. They also appear to increase exercise endurance. So these are both important outcomes to patients. The problem comes when we start to look at benefits of opioids in daily life trials. And this was the practice guidelines drawing together of the clinical trials done, pragmatic daily clinical studies done in respiratory disease. And you can see no difference for the outcome of breathlessness. There are a few points to note if you look at some of the variation in those studies, some things to highlight. Oh, yeah, so therefore the benefit of opioids seen in the laboratory setting does not appear to translate into the clinical practice setting if you take that outcome measure of breathlessness. So bear in mind, the Abernethy trial, there was statistically significant improvement in breathlessness. However, of note, the eligibility criterion was that patients had to be breathless at rest. So the issue of that interplay between your perception of breathlessness and how much physical exertion you've done to be that breathless is much less of a tangle. Just to highlight one of the things that the ERS statement said, not clear if opioids are beneficial in people with more severe breathlessness, where there is at least one study done at rest, but it is only one. If you look at the Kronberg-White study that was done in ILD. That was a positive study. It was only a small sample size and with wide confidence intervals. But again, it just highlights that there are very few data on people with non-COPD lung disease, but there is that trial. In the Verbert trial, of note, the primary outcome was the CAT, quality of life measure for COPD, and that was a statistically significant improvement in the morphine group. When they looked at the subgroup of people who had MMRC 3 and 4, so those with moderate to severe breathlessness, they also found a statistically significant improvement in the measure of worst breathlessness. Again, the people who are less likely to have that issue of physical exertion muddying the waters. Note, none of these studies in all of that forest plot had breathlessness measured at ISO time or ISO load. And people in general will exert themselves until the same level of breathlessness stops them. So breathlessness intensity may be unchanged whilst being able to do more. And just to drive this home, because it's one of those things where I think those of us in this field feel a bit sheepish, really, because we should have tumbled to this way back before. And one of the, I think, learning points is to work with your laboratory scientists, work with your exercise physiologists, who we do now, and we have got better at doing that. And I think our regret is not having had such a measure in the Mabel trial, in the Beams trial, etc. So let's just give you an illustration. So this is just to prove I have done the Great North Run, a half marathon, 3 times no less. And in fact, that's me just coming in hot on the heels of Spider-Man, which I'm very proud of myself. You know, that's not bad, isn't it? Just, I mean, I don't mind being beaten by Spider-Man or Superman, but there I am, crossing the line, not wanting to know whether I was going to, realizing I'd quite like to cry with emotion, but then thinking I couldn't cry and breathe at the same time, so I didn't. Now, when I started training for this, I couldn't run to the fridge. And I remember going out one night at dark, after dark, dressed in black, because I would rather be run over by a bus than having been caught running. And I got about 100 meters and I had to stop because I thought I was going to die. And if you'd asked me, I'd have said I had 10 out of 10 breathlessness. Now, a month later, I also had to stop on a training run, feeling I wanted to die and having 10 out of 10 breathlessness. But I'd run a mile. Now, if the only thing you took into account was my score of 10 out of 10, you could conclude that training for a half marathon does nothing for your breathlessness. However, if you take into account how much I had done to be that breathless, if you'd asked me at 100 meters, I would have been much better. In fact, by then I was starting to be able to have small chats to the people I was running with. So I just want you to get that clear in your head, because I think that understanding is very important to this whole issue. So, and then if we look at the Beams trial, in the sub-study, exploratory sub-study, looking at physical activity data, if you look at, this was a complex design, so there were 4 dose morphine arms and 1 placebo. If you look at the placebo, which is the blue line, for both mean active calories and time spent in light activity compared with sedentary activity, it gets worse from baseline for both of those measures. Whereas if you look at any of those opioid arms, they have spent more time in light activity compared to being sedentary, and they have expended more mean active calories. So there is a signal of benefit at the 3 weeks from sustained release morphine. And physical activity, being able to do, going up a flight of stairs in a oneer is a quality of life issue for people who otherwise might have to stop 2 or 3 times to get their breath back before they get up the stairs. So physical activity is a very clinically relevant outcome measure. So Mabel, was this the final nail in the coffin? A spoiler alert, our primary outcome of NRS worst breathlessness was no different between morphine and placebo arms. What did we do? We did a double-blind placebo-controlled trial of modified release morphine orally twice daily. We had moderate to severe breathless people they were breathless due to cardiorespiratory diseases or cancer. We recruited from 11 sites. We had a dose titration step possible at day 15 for those who had not improved breathlessness by a moderate effect size of 1 point on the NRS scale, balanced against emergent harms. We collected placebo-controlled data to 56 days, and we had adequate statistical power to discard the null hypothesis. We had a range of secondary outcomes that you can read there, including health service utilisation. And a shout to King's College London, who were invaluable on this trial, with Sabrina heading up the clinician training and recruiting like one possessed, and to Irene giving us valuable advice on the co-investigator team. We had 140 in the intention to treat population. It was predominantly male, predominantly older, vastly predominantly chronic lung disease. It was very difficult to recruit from heart failure because of challenges in engaging the cardiology community, and very difficult to recruit from cancer because of the issue of the need to be opioid naive. The vast majority were multimorbid, and the vast majority were of white ethnicity. Morphine, we taught the clinicians how to monitor and to manage side effects early. And I think this is partly, well, I think this is why, and the dose escalation step, the morphine was much better tolerated than in previous morphine trials. We had 88% had at least 90% adherence by day 28. Looking at the dose escalation figures, more participants in the placebo group opted for dose escalation compared with the morphine group. However, as I said, no difference, not a spot of difference with the primary outcome. Their worst breathlessness in the previous 24 hours was fairly resolutely the same. Looking at safety, this is pretty much as you would expect from a drug with a known safety profile, side effect profile. There were more adverse events in the morphine group. There were more serious adverse events in the morphine group, although when you looked at whether they were related or not to morphine, this dropped from 15 to 3 and from 3 to 0. We had more study drug withdrawals. Most morphine toxicities were gastrointestinal. They were mild, self-limiting, except for constipation, which you had to keep an eye on all the way through the study. Interestingly, we did not demonstrate any excess sedation or cognitive impairment between the two groups, and we had no instance of respiratory depression. We had 2 morphine group deaths, one from chest infection, one from myocardial infarction. Neither were related to the morphine, and 1 placebo group death from congestive cardiac failure. Secondary outcomes. This is where there was some interest. There was no difference for any except physical activity and cough. And like the BEAM study, we found point estimates in favour of the morphine group. Now, you've got to be a bit careful with actigraphy. We used wrist actigraphy, which overestimates the level, the amount of physical activity in terms of whether it's light, moderate, or vigorous. But you can't mistake sedentary activity. So I think a reduction overall of 20 minutes of sedentary behaviour is something which is worth looking at. And the cough findings, given that it's such a troublesome symptom with few interventions, is worth looking at. Of note, once we corrected for multiple comparisons, only the cough findings remain statistically significant. People have asked me, why is it only become statistically significant at day 56? And I think that's probably because if you look at the point estimates, the placebo group keep getting worse, whereas the morphine group stay around the same from day 7. The improvement in cough was seen between baseline and day 7. We also looked at the subgroup of people who were recruited through pulmonary rehab. Now, this is exploratory data, none of it statistically significant, but I put it in because I think it's quite interesting. If we are thinking that one of the ways in which morphine may help is by helping people with exercise endurance. And we know that breathlessness is a reason why people, A, don't get to pulmonary rehab in the first place, or if they do, they struggle to complete it. Now, if you look at the group who were recruited through PR, their breathlessness was lower than the group recruited not through PR. The benefit in the PR group with morphine was a moderate effect size. Looking at the point estimates, there's a moderate effect size compared with a small effect size in the placebo group. And of note, the lower confidence interval bound includes a large effect size. So there were some people there having a significant benefit. The question is worth thinking about, and again, I would welcome Matt and Charlie thoughts on this, is that given that across the piece, with all the evidence, the only predictor really of a better response is higher baseline NRS breathlessness. So why should this group appear to have a greater response than the group not recruited through PR? But we can have a think about that. It would be good to get your thoughts. Health economics. Excuse me. The mean differences were calculated with day 28 and day 56 quality of life adjusted, quality adjusted life years, and from the EQ5D, the short form 6, and the IceCap SCM scores at 56 days. In general, there were more inpatient and fewer outpatient services in the morphine group versus placebo, and there were small non-statistically significant increases. So basically the morphine group cost more, £24 per participant on average, but they gained more QALYs than the placebo group. The cost was driven by inpatient stays. And when we looked at all serious adverse events, then the probability of being cost effective at day 56 was only about 54%. However, when we looked at the scenario analysis, looking at related SEs only, the probability of cost effectiveness increased to 73%, which is in keeping with the only other health economic evaluation done, which was done by the Nordic trial team in the Netherlands. So points for consideration. We didn't measure exercise endurance. So we don't know the work done to generate the breathlessness score. We think that future work should include measurement at ISO time or ISO load. Physical activity findings are consistent with the BEAMS sub-study. We think it's a highly relevant patient-relevant outcome. And if you look at the WHO recommendations for people with chronic conditions, they say any reduction in sedentary activity is recommended. I've also noted that the wrist-worn actigraphy overestimates steps and time in moderate to vigorous, but the sedentary data should be unaffected by that. Cough, this is consistent with other small trials. We suggest this should be explored further with a validated tool. We just used an NRS worst cough in the previous 24 hours. The apparent delayed effect may be a feature of the placebo group getting worse over time. We added another 36. We added more data to people with ILD on top of the Kronberg-White 36 participants. With the safety, we found that adherence was better than other pragmatic trials with a low starting dose and close monitoring. It's so important to note that constipation does not sort itself out. It requires ongoing management. And in fact, looking at the 3 hospital admissions that were related to morphine, 2 of them were in relation to constipation. So if that was managed optimally, that could have been 2 admissions avoided. People undergoing pulmonary rehab, previously the only data were on 6 participants. So we've added more to that database. It would be great to have a trial. Safety, trials to date, consistent, side effects common, mild expected, and self-limiting, mainly in the first week. Morphine has a known safety profile and should be prescribed, as with any other drug, for the right patient and with due care and monitoring. Some harms, however, are still unknown. For example, immune effects, although we didn't see an excess of infectious adverse events, and the population level observational studies, for example, one that Sabrina Bajwa was involved with ILD, shows no excess hospitalization or mortality with doses less than 30 milligrams a day in people with ILD or COPD. The BEAM sub-study showed no relationship between morphine and testosterone levels over time. We need some common sense care regarding driving. We're awaiting the BEAM subgroup study findings. Beware fluctuating renal function. This is common sense again, isn't it? Particularly for people with heart failure, where they can have fine renal function one day, their diuretics are increased the next week, and then it's all gone to pot. So in conclusion, we found no evidence that morphine improves worst breathlessness intensity over the previous 24 hours over 4 weeks. And we need further research to understand if there's any role for morphine in chronic breathlessness, particularly regarding exercise endurance and severe breathlessness, including at rest or cough. So we were very interested to see that we had an accompanying editorial published with the MABEL trial in the Lancet Respiratory Journal. They complemented, it was by the team who presented another negative morphine trial at the European Respiratory Society last September. They did a short crossover study of morphine, fentanyl, and placebo, using, again, not using any exercise measures, but showed negative outcomes. They complemented our robustness, which is always nice, isn't it? They noted the potentially clinically useful secondary outcomes of physical activity and cough, but then they concluded, somewhat to my surprise, that it was time to say goodbye to morphine for chronic breathlessness, which I have to say felt to many of us on our team that it was throwing the baby out with the bathwater. Interestingly enough, we were allowed to reply in the journal, but we weren't allowed to use the phrase baby out with the bathwater for fear that people around the world didn't know what we were talking about. Maybe they just think British people are very cruel. So how do we respond when clinical trials do not confirm laboratory benefit? Do we assume, well, the laboratory findings just don't translate to real life, which I have heard a number of people say, or do we ask, well, why does the benefit for breathlessness perception seen in laboratory trials not appear in daily life trials? And there's a very nice piece written by Magnus Ekström by this, if you want to see a little bit more discussion. Is it the intervention that doesn't translate, or is it the outcome measure that doesn't translate to real life? And is there a scientific rationale for this observation? And I would put it to you that actually, given this lack of knowledge of how much someone had exercised to become that breathless was a big problem. Also, look at all the data. Is there a pattern across studies and outcome? For example, if you look at all the outcomes and in all the studies, there are signals of benefit in many, whereas in the antidepressant studies, for example, it seems to be much more uniform that it's not doing much. Do these data signal patient-relevant, do these data, try again, signal patient-relevant clinical important benefit worth further research? Like, what is the value of information to patients? And if so, how does this inform future study questions or design? So my summary, before you can all jump up and down and say what you think, the verdict. Do opioids improve breathlessness and exercise endurance in laboratory trials? I think we have to conclude, yes, they do. Do opioids improve breathlessness at rest in clinical study? Well, I would say on the basis of one trial, yes. Do opioids improve breathlessness and exercise endurance in ambulant people with moderate to severe breathlessness? I think we can only say maybe. Is long-acting morphine tolerated well with appropriate monitoring and in appropriate patients? I think we conclude yes. Our findings are consistent with the ERS guidelines regarding considerations regarding their consideration should a therapeutic trial be initiated. We further suggest a starting dose should be no higher than 5 BD, that co-prescription of laxatives, close monitoring and early management of expected side effects during those 7 days or of dose initiation or increase is absolutely mandatory, especially for nausea, because we found there was a tendency clinically for people to say, oh, well, it'll settle by itself. If you don't jump on it, people have given up and they've stopped taking the morphine. Got to keep on constipation. You can't figure that it's sorted out. Dose escalation should be according to an explicit assessment and weighing up of harms and benefits. And if you do want to use this in your clinical practice, then a measurable physical activity should be agreed with the patient and an assessment of treatment response judged in relation to that rather than just breathlessness self-report. I mean, for example, I can remember a patient who he was quite extraordinary. He used to time himself walking to the local supermarket. So that was his measure. And if morphine helped him get there quicker, then he thought it was doing something. That was his judge that it was doing something. Research implications. Well, physical activity data are signaling a clinically important benefit. And I feel, our group feel that no further studies in ambulant population should be done without some sort of standardized exercise test, although we're not exactly sort of totally clear what that should be. Note that we are planning to pool the data analysis of the physical activity data from BEAMS and MABEL, so that will give us increased statistical power. And note that pooled data analysis of NRS worse in people with MMRC3 or more from the MOP, BEAMS and Maudic trials will be reported soon. Would a prescription of morphine during pulmonary rehab allow better adherence and greater benefit for those attending? Our data from the withdrawal data show you can start and stop after 8 weeks. There were a few people who had some withdrawal symptoms, but nothing that caused undue excitement. So far, phase 2 trials have failed recruitment stop-go targets. Only one daily life trial recruited patients at rest so far, that is the Abernethy trial. As the ERS statement points out, patients most likely to receive morphine are those in the last weeks of life, and a trial in this population will be useful. And Thomas Similowski in Paris is planning one in the ITU population, and Magnus Ekstrom is, I think, imminently starting one in a nursing care home end-of-life situation. Just of note, these are some of the longest placebo-controlled data published to date, but we do need more long-term data regarding harms, particularly about the infection side of things, to get a better idea. So thank you. The full report, including all the sub-studies, including open label follow-up for up to 6 months, predictors, caregiver gate data, withdrawal data, that is about to be published in the NIHR Journals Library. And if you are interested and in your clinical practice you do consider patients for a therapeutic trial of morphine, you can access a patient information leaflet and a video for them through that link, and that link will be sent round. I'm looking at Sabrina, I presume so. So thank you for your attention, and I will now stop sharing so we can chat.
Thank you, Miriam. That was a fantastic presentation and incredibly invaluable. And congratulations on your leadership on the MABEL trial, which was amazing. And it was a delight, I think, for everybody at King's College Hospital to recruit to this study. So thank you for asking us to be involved. Please do put your hands up if you have a question or you want to come in with the in the discussion. So Matt.
Yeah, I'll start. So yeah, thanks Miriam, thanks for a really informative presentation and lots of very rigorously and carefully collected data. I'm kind of agree and equally interested in how you see opioids, morphine being useful for during physical activity and during exercise. I think it, like also in pulmonary rehab, you can improve someone's exercise capacity, and there's a nice paper by Waddell, I'll put it in the chat, shows in which ways pulmonary rehab and supervised exercise changes dimensions of breathlessness. But it's not very good at improving people's physical activity levels. So it's potentially there's a kind of supplementary effect of morphine during to augment exercise training. And then a last thought about the physical activity measure. It's notoriously tricky to capture some of the benefit with breathlessness, and this proactive measure, which was usefully developed with European Medicines Agency and the pharmaceuticals regulators, is capturing both the amount and the difficulty of physical activity. So there's accelerometry and a patient-reported kind of experience reflection, and that might be very nicely aligned. But then my question and maybe challenge is that we're often recruiting on the basis of a very blunt measure of breathlessness, but we think we're intervening with a different dimension or a different domain of breathlessness in this drug. So you recruit people based on a functional limitation, yet you think you're changing the affective dimension of breathlessness. So kind of challenge to you, but to the whole community, really.
Yeah, and I think you've summarised the challenges that we're facing, and it's the sort of interesting and exciting thing about research, but also the frustrating thing about this research, particularly in an area which is relatively new in research, is that you make your mistakes as you go along, and you learn from one trial, and then your mistakes then inform the design of the next trial, which informs the design of the next trial. So that's why Beams and Mabel had physical activity in it, because we were starting to twig, hang on a cotton picking minute, this is a different patient population. We're not dealing with people sat in bed incredibly breathless like the Abernethy trial. And trying the MMRC for an eligibility screen, I would say, has got real challenges to it, because it is, by nature of the way you recruit people into the trial, it is the clinicians at the coalface who make that assessment. And I would say it's incredibly variable as to how they make that assessment. And we found that we did have to try and train sites to say, please don't just make the judgment of what they look like sat in the chair. You really do need to drill down quite a bit more about what they're doing on a daily basis, and more often what they're not doing. We found, particularly some of the early studies, clinicians were just saying, are you breathless? And the patient would say no, because they're sat there, they've been waiting in the waiting room for half an hour. They're nearly unconscious, let alone breathless. Whereas if you say, what have you stopped doing, or what has slowed you down because of breathlessness? Well, and out comes this litany of how breathlessness has limited them. So I think we still are struggling with that issue. And also in terms of standardized exercise measures, one that is validated for the patient group who can't necessarily manage a shuttle walk test. One of our fan studies, for example, we use a shuttle walk test, and the patients just basically voted with their feet of not doing that. So we had so much missing data, it was unbelievable. The other thing around the difference between what people will do under test conditions with some nice researcher yelling at them is very difficult to what people will actually do in their own homes. And you can argue that the patient relevant out measure is what they actually do day by day, rather than what they can do, the can do gap, as it's been called. I was reflecting, it's interesting that in the Mabel trial, Beams trial, we didn't give them any kind of exercise hint. There was nothing in it about morphine might help you do more. It was just about the breathlessness. And yet we saw this change in levels of, reduction in sedentary behaviour. And I wonder what we would have seen had we said, try doing a little bit more in both groups. Would it add to advice, which again is that a little bit that overlap with pulmonary rehab? If you've got your exercise, if you've got your brain a little bit dulled to the horrible messages of breathlessness coming in, does it mean you stick at it more? So, there's still lots of unanswered questions, but I think in my mind, it is hard to ignore that there is something there. If you look at the whole evidence base, it's the question of what is its place in clinical practice, for what clinical population, and with regard to which outcome and outcomes. We also have a big problem in symptom control research, whereby we try and squeeze it into this rather rigid paradigm of one disease, one thing, one measure, whereas we know that symptoms are experienced holistically. You alluded to that, Matt, and I think you're absolutely right. and looking at study designs which allows you to include more than, to get away from the one question, one outcome. We so nearly had physical activity as a co-primary outcome. And the only reason we didn't was to get the costs down for the HTA application, because it plays havoc with your statistical power and the sample size that you need. We were this close to having it as a co-primary outcome. If we'd had it as a co-primary outcome, there is no way we would have seen that accompanying editorial in the Lancet Respiratory Medicine. Sorry, that was a bit of a long rabbit, but thank you, Matt. You encapsulated that beautifully.
Miriam, I realise that there are a lot of people on this call who are from clinical teams, and I think it'd be really, it was great to see the latter slides in terms of clinical practice, but I can't tell you the amount of times that I've been to conferences at the moment, and we're hearing this message about it's time to stop prescribing morphine, or that there's no evidence for morphine in breathlessness. And I just, in terms of clinical practice, I think on the ground, what do you think that clinicians and health professionals meeting these respiratory patients really need to think about?
Yes, and that's something which, this is partly why, my heart sank when I saw the headline of that editorial, because I thought it's just struck me as being a bit unscientific, really. You comment on the robustness of the data, you comment on the potentially important measures, and then you say, right, time to say goodbye, bye-bye. And unfortunately, many clinicians are just so busy. The pressure of everyday practice is so enormous. Why would we expect them to be reading the minutiae of the fine discussions and, understand all the detail of the nuances of study design, etc.? They'll read a headline, and journals will only let you publish the primary outcome mainly in the abstract, although we were lucky, actually. They did allow us to present the secondary outcomes, but as a general rule, people will read the headline, the abstract, or worse still, just an accompanying editorial strapline, and not look at it for themselves. So I would say, take it in the round, ask those questions. Why have we not seen that change? Is it because we're looking at the wrong thing? So I think the on-the-ground advice is, I would work on the assumption, if it's doing anything, and I agree we don't yet have that definitive trial for ambulant patients, if it's doing anything, taking all that we know about it, it's likely to be working through both reduction in breathlessness in the very, very severe people, but also increasing exercise endurance. So blunting that perception so you can do more for the same amount of breathlessness. So your function improves. So I would say, if you've got an ambulant patient, I would say, right, what is important for you to do? What would it take for morphine to help you with to make it worth taking morphine? I had another patient who their goal was to get to the bus stop 200 yards down the road. Because if he could get to the bus stop, he could get into town. And if he could get into town, he could get to the Rosebery pub with his mates. And his quality of life just leapt up by several degrees. And morphine helped him get to the bus stop in town. If you asked him, is your breathing any better? Oh, no, that stuff you gave me is useless. But he was down in the Rosebery pub, life and soul of the party, having a whale of a time, whereas before we started it, he wasn't. So I think it's about, what would it take for it to be worth it for a patient to have it, and then you review it, and if it's not helping, you stop it. Does not help everybody.
Yeah, no, thank you. And I know that's certainly what I do now, that not only preempt and after the Mabel results, but, preempt that it may help with your breathlessness, but it may also allow you to do more. And I always ask now when I'm assessing the effectiveness of morphine in terms of breathlessness and if they're able to do more. And what's really interesting for me is to kind of see from the MABEL data the adverse events and the safety data around respiratory depression as well. I think that it's really helpful to see that in wider conversations, I think, with respiratory teams. And I can see lots of our respiratory colleagues on the call. So so first is it Jojo?
Yes, hi. Yes, my name is Jojo. I'm one of the clinical nurse specialists, and I do see a lot of patients in the community setting palliative care. I mean, it's still very common that we still use morphine to treat breathlessness. And in some time, I just want to ask some research about it. So basically, we understand from your results shows that morphine is not particularly useful to treat breathlessness and severe breathlessness at the moment. But we're still using it because sometimes when patients they complain they can't breathe, you know, towards the end of life, they really struggle. And sometimes we will top up with benzodiazepine because we understand, you know, breathlessness can trigger anxiety, and I feel like they stuck in this like vicious cycle, breathlessness and anxiety, breathlessness, anxiety. Is it so far? Is there any research or evidence to support combining low dose of benzo with morphine can actually, you know, ease breathlessness as well? You know, yeah. Thank you.
So, well, firstly, I would say that there is evidence that morphine helps breathlessness in those who are severely breathless at rest. The Abernethy trial shows that if you're breathless at rest, there is one well-conducted, adequately powered study to show that it should improve breathlessness. Combination with benzodiazepines, it's still a bit of an evidence-free zone. The only thing I would say is that Magnus and Sabrina's observational data. So Magnus did both papers, one in COPD, one in ILD. Sabrina helped with the ILD paper, looking at population level data of patients with breathlessness who were on morphine and benzodiazepines. Where they were on it together, that's when you started to see a little bit more signal in terms of hospitalization and death, but only once you started getting above a significant a certain dosage, which Sabrina, I'm hoping, might actually remember off the top of her head. But also these are observational data, and it's very difficult to know whether is that causal, or is it that this group of patients are now by nature very, very likely they're having their morphine and their benzos together because they are at that stage of life where they're very likely to die or be admitted to hospital. So I think the question is, I would use, in terms of the anxiety, I would always go make sure you've done all the non-pharmacological stuff you can do, because that is hugely beneficial. And you may get away without needing a benzodiazepine at all. However, there are some situations that we've all been in with the patient absolutely on the ceiling, in that dreadful cycle of breathlessness anxiety, as you described, where having the little blue pill, the short-acting benzodiazepine available, or midazolam, or whatever it is, something short-acting, can just help ease them around the rocks in the last few days of life. But in terms of trial evidence, it's scant if there at all. And I think you have to be very careful. You have to monitor it. And be very careful about the dose used and try to keep the dose to an absolute minimum. Sabrina, do you have anything to add to that?
Yeah, so thanks, Miriam. So Magnus's paper in the BMJ, and I'm trying to find the links, it does show with COPD to limit the doses to 30 milligrams of morphine in 24 hours, but there's no limit in terms of morphine in our ILD paper in the ERJ. In terms of benzodiazepines, there was an association of higher mortality and morbidity in both diseases. In doses of lorazepam, more than 1 milligram in 24 hours. So I have to say, personally, I don't prescribe benzodiazepines for breathlessness unless people are at the end of life, or it's for a very short bridging time and prefer to prescribe mirtazapine for that reason. But thank you for your question. I think incredibly important, but I wanted to bring LJ in as well.
Thank you, and thank you for the presentation. Great to hear that update. I'm a respiratory consultant at King's, and I just wanted to reflect just the sort of clinical experience at the moment. There's been a lot of sort of chatter recently around, what's this, editorial saying don't use morphine, because our experience is that there are a set of patients who this is extremely beneficial for, both those with very extreme breathlessness at rest and those who have chronic breathlessness, chronic disabling breathlessness, but are, up and about out of hospital. So we were quite, we haven't dug into all of the data, so I'm grateful for you for having examined it and reflected on it for me, so that's very helpful. But certainly we were quite concerned about that conclusion. I think the kind of thoughts around being really clear on what the attempted outcome is, and actually what you've said today about being clear about what the patient's goals are, I think we could be more explicit about that in clinical practice. But we very much do a trial of treatment, and we start with low doses and we build up, and we try and monitor symptoms. So I think it's reassured me that actually it's not quite so bleak. We know the evidence around any medication treatment for breathlessness has always been, it's hard research to do, so the evidence is always going to be relatively limited. But I think this helps add to the knowledge in a really important and significant way. And yeah, the discussion today has just reassured me that there is good reason for us to continue in specific patient populations with very clear, and that's I think what I'll take back and reflect to the team, to be really clear about our aims and whether that's reduction in perception of breathlessness at rest in that patient group, or whether it's achieving aims around mobility and trying to make that more patient-centered. So thank you.
Yeah, and it's very interesting. It is such a polarizing topic. It's a real kind of Marmite thing, morphine for breathlessness. I don't know what that polarization is driven by. Certainly, I'm old enough that in my medical school days, I was taught the day thou givest morphine to a patient with COPD is the day they shall surely die. As I was also taught the day thou givest morphine to a patient with beta blockers to a patient with heart failure is the day they shall surely die. It's just that the understanding over time, as the data come through, has changed our understanding and modification. But I do think there is still a spectre. And yes, if you give morphine unrestricted to a patient, which I have to say is partly why, apart from the data, partly why I would use modified release and not immediate release. I think sending someone off with a bottle of immediate release morphine and say swig when you feel a wee bit breathless, I think is a recipe for respiratory depression, quite frankly. I just think that is, you could easily kill people with morphine. Of course you can. It's a known risk. Just like you can with digoxin, or if you give chemotherapy to the wrong person, it's not a good idea, It's about being kind of keeping your head. But I think, how many rounds have we had? Was it 6 reviewers, I think, Sabrina? I think it was something like 5 or 6 rounds of reviews, another 3 or 4 rounds with the editors, who'd obviously picked up that there were extremely polarized voices. From people who thought it was the best thing since sliced bread to the people who thought it was of the devil. Seems to be no halfway house with this, and treading that tightrope, trying to be absolutely honest to the data, trying to be academically transparent and not overclaiming, recognizing your own biases, has been an interesting road, hasn't it, Sabrina?
Yeah, and I think one of the most interesting things I found was it kind of supporting, what I thought was done really well in the MABEL trial is supporting people in managing the side effects of morphine as you go along in the prescribing, in terms of routine supporting around constipation and nausea, and how that makes that experience of taking morphine so much better and means that people do adhere in a much better way. And I don't think we do that well enough within our clinical teams. So, for me, that was a real learning and something that I took away. So, yeah, brilliant.
Yeah. And do check out the patient information leaflet and the video. It's very sort of easy to understand animation, and it's all based on the training program we had with Mabel and the outcomes from Mabel. So, you know, it's there to be used. You'll find it on the Wolfson website, and the link is there in the slides that will come around, I guess, a PDF version of some sort anyway.
Yeah, and so hopefully we will be circulating a PDF version of the slides and some of the relevant studies that we've talked about today. So thank you again to Miriam for an amazing presentation, and it's been incredibly invaluable to have the discussions around future research in this area, but also it's been incredibly helpful to really kind of clarify how we should be using morphine in clinical practice for these patients who have a really debilitating symptom and in their advanced disease. So I'm going to bring the session to a close, and thank you to everybody for attending today. I think at one point we had over 100 attendees, and so thank you. The next seminar will take place on the 27th of May at 4 o'clock, and details will follow soon. And please do let us know if you've got any future ideas for future seminars and other great speakers like Miriam. So thank you again.